Let's start the next case about the non-union of the femoral shaft fractures. It's a bit long story. She is the 30 years old female, and she got a car accident since 10 years ago. At the initial hospital, they did sorry, I don't have the initial X-ray, but they diagnosed as the cross fracture femur, and they did the ORIF with board DCP and wiring. 6 months later, the patient failed, and she was transferred to the private hospital. And the patient told us that they got the true operation to remove the plate OIF with IM nail and bone graft, and in one further operation is the revision nail. This is what we get, the oldest X-ray we get. This is 2 years after ORIF with intramedullary nail with iliac bone graft. The patient can walk with pain at right thigh. They follow for almost 1 year later. It's still non-union with some hypertrophic callus. 3 and 6 years, she still got pain, especially on thigh and hip. And you can see that the nail was, the body tried to auto-dynamize itself to break the distal locking screw. At that time, the surgeon decided to do the dynamization again. They removed the proximal locking screw. Now there is just only nail in the medullary canal without any locking screw. Then this is the X-ray follow 6 weeks after dynamization and 5 months after dynamization, totally 4 years after the initial surgery. She still got thigh pain when walking. What's next? Surgeon do the further operation. They did the exchange nail to the more larger nail size 13 without bone graft. And then this is what I get. Follow up 1 year after exchange nail. It still have the thigh pain when walk in long distance, but in short distance it's clinically union. But we can see that she got the radiographic non-union. Then what to do? The surgeon decided to wait and see. Yes, this is 3 years later. Totally 8 years after the initial operation. She can walk in a short distance, but she cannot walk in a longer distance or run. So now it's your turn. She came to me and asked the opinion. Did she need to do the operation at this time? Clinical, for the clinical, they get some external rotation deformity on right side, but the functional is quite good. This is a CT scan. We did a CT scan to confirm that there's still the fracture line, that's to prove that there is non-union at the fracture site. This is the sagittal view, and this is the axial view. When we investigate, we found that there is some limb length discrepancy now for 4 centimeters with radiographic non-union. Our problem list is it looks origo or hypertrophic non-union now. After intramedullary nailing, after bone graft, and after exchange nailing, and there is some limb length discrepancy. We discussed with the patient, and we think that the hypertrophic non-union, now we got very stable fixation. The nail is maybe the largest, it's 13. And what we need for the non-union side is the compression. For the limb length, yes, we want to distraction osteogenesis, to lengthening the bone. So we discussed with the patient and we plan to do the lengthening over the nail with compression at the non-union site. This is our plan. First, we will remove all the nail. And then we insert the guide wire and do the osteotomy. Sorry, we do the low velocity osteotomy. Ajahn Wachara may not like this, but my resident do really aggressive corticotomy for me. And then we have the corticotomy at the proximal femur. We put the nail in with only the proximal screw. And then we apply the monolateral plane dissector. We apply the Wagner dissection device. After latency period, we dissection the femur to plane length. After that, we put the distal locking screw and continue dissection to create the compression at the non-union site for 3 to 4 weeks. And then we remove the Wagner and waiting for consolidation. So this is our plan. And we do as we plan. We do the corticotomy. We dissect it after 1 week, 2 weeks, and with the Wagner with a bit low profile compared to the circular ring. So the patient can very comfortable with that. After we dissect, to get the required length, we put the distal locking screw in and then continue dissection and waiting for consolidation, and it heals when the time passes by. We regain the length and we got the union both on the dissection side and also the non-union side. We confirm with the CT that the non-union side initially is already union. And the function is good. We allow, because of the low profile dissection, we allow them to do the hip and knee range of motion during the dissection period. So the take-home message is, you can see that this is very long story. The treatment of the non-union depends on the cause of the non-union. You need to find the cause of the non-union. You need to balance between the mechanic and biology. If it mechanic incompetent, you need to add more stabilization. You can do the exchange nail, or you can do the plate augmentation, for example, for hypertrophic non-union. But for the impaired biology, maybe we need to do the bone graft and also compression at the fracture site. And limb length may have the important role in this case because of relatively short limb. Maybe unload the compression all the time. If you got the proper length, when you walk, you get more compression when walking. Thank you.
Thank you. Okay. I think we have the champion for the wait and see.
Right?
Because
Do you think
how many years? 7 years.
the longest
long.
one? We should have this longest one.
Yeah.
Yeah. But fortunately, she met you, right? Okay.
Please, any comment?
Any comments from the panelists?
So I may say that 3 times congratulations for the patient and for the surgeon. I think that the point is why this patient failed from the many times operation. Is it stability? Is it biological? I'm not sure about the biology of this bone is a problem. But maybe I can see the colors like a huge colors. The main problem is the axial rotation or the rotational stability. I think that in this case maybe it's rotational stability. If we face something like this earlier, what is next? What is your plan? Do you put the bigger nail and bigger and biggest? 16, can we solve this problem? I'm not sure. But if we added more rotational stability, sometimes you may not need to do many operations like this. I'm not sure. Maybe I ask the comment from the panelists, please.
Just want to add, in this case, what have you learned? Let's say, in general, if you have a non-union with the nail, right, and you have a screw, we thought about dynamization first. However, in some case, if you do dynamization, you even increase more instability. That is the point, number one. Number two, when it's failed, again, we usually take the nail out, ream, and put the nail. And most of the time, 70% it's success. However, when you do this and then you follow up, how long? Come back, wait and see. My cut point is 5 or 6 months. If I don't see well, callus and all this, I do CT scan. And most of the time when you see, you know that it will not heal. Because when you look at the X-ray, you only see 2 dimensions. But CT scan showing you, then you don't have to wait like this. You know, altogether, I have similar case that even worse is 9 years. Right? So surgeon, when he doesn't see the nail break, he said, oh, we keep waiting and waiting and waiting. The next point is, okay, we can make it heal, but if heal with 4 centimeter shortening, is that acceptable? Because you may say, okay, we take out, we put compression plate, it heal, yes. But is 4 centimeter acceptable? If not, you have to think how we treat non-union and at the same time, we lengthen it. Right? So there are many points when you look and analyze how do we treat the patient. I just want to add all of these points. Now, one technique that we use today is when you put the nail and it doesn't heal well, instead of changing everything, if the patient has the right length, we just add 1 plate to increase stability. You don't have to remove the nail. You just put the plate and add some screw. And we have a series where it shows that, and also the paper to support this technique.
I just want to ask Dr. Chittawee one question. When you do the compression at the distal with the distraction,
Yeah.
did you have to open and resect the bone graft, resect the non-union side, or you put any bone graft in?
We did do anything with the non-union side. We just analyze that it needs compression and we do the compression.
So I think this is a very good point, because that means that this case is totally failing from the biomechanics. Because you did not do any bone grafting and you did not have to clear the fracture side. Yeah.
The bone graft was done from the first
Yes.
surgeries. That means, okay, you have some. You see the callus formation. But if you look from this X-ray on the most rightmost, right? You see the canal is very wide on the distal. It is unstable. And even they try to increase, this is the biggest nail, I think this is the biggest nail that the surgeon have at that time. And he have to cut the end because I think there's no correct length.
I think because it's shortened too, 4 centimeters.
Yeah.
So how you compress the fracture gap?
With the dissection device, after we fix proximal and distal, we
So
continue.
he locked the distal and then
Yes.
still
Compress
distract.
and lock.
Yes.
Yeah, and
Okay.
this track
No,
the
he-
segment down.
He locked
you
the
mean
distal
by
and
the
continued.
distraction?
Yes.
Yes, by the
Okay.
dissection.
So I just make 2 comments, very short because the time is out. One thing, the pinning to do the in the femur, that is the right position. In the lateral aspect, you can do just a little bit anterolateral or posterolateral. That is very good. You mentioned about biology of the corticotomy. In tibia and femur, it's different. Corticotomy in tibia is very, very serious because you have to preserve the blood supply. You have to do corticotomy, otherwise the blood supply, it will be very long time. Femur is different because the blood supply of the femur is quite adequate and more than adequate. So even you do osteotomy, okay, I may preserve more,
Yeah.
but this is forgiving in femur.
Okay.
Okay, thank you. Thank you, Dr. Chittawee.